Hi, everyone. Thank you for joining us for today's webinar, the HRSA UDS Sealant Measure 2021 Annual Update. My name is Candace Owen. I am NOAA's Education Director and today's moderator. Our learning objectives for today is to understand the impact of COVID-19 on the HRSA UDS measure, review the data elements needed to compute the UDS Sealant Measure, describe strategies for improving on the UDS Sealant Measure outcomes, and learn some strategies from One Health Center, Vista Community Clinic in California, and how they have developed processes to increase its UDS sealant measure percentage. Before we get started, just a couple of housekeeping items. Your phones will be on mute, but you can submit your questions into the question box at any time during the presentation. We will get to many questions as possible towards the end, and any unanswered questions will be sent to the speakers for a direct response. This webinar is being recorded and will be posted to the NOAA website later next week. A copy of the presentation slides will be sent through the chat box shortly, but also be posted on our website next week. Following the webinar, a short survey will be emailed to you and will pop up on your screen so you can provide feedback and to receive continuing dental education credits. You must complete the survey in order to receive the CE credits, and you must complete the survey by close of business Tuesday, December 7th. So now let me introduce our speakers. Our first speaker is Dr. Irene Hilton. She is NOAA's dental consultant and also a clinical staff dentist at the San Francisco Department of Public Health. She is a board certified dentist in dental public health and is on the faculty at the University of California, San Francisco School of Dentistry. Since 2015, the introduction of the HRSA UDS Sealant Measure, Dr. Hilton has participated in the development of NOAA's training and technical assistance resources to help health centers develop this evidence-based procedure to more children. Lieutenant Commander Shayo Adunola is a graduate of the University of Maryland, College Park, and public health. She also is a graduate of the University of Maryland, Baltimore School of Dentistry, and the University of Maryland, Baltimore School of Medicine for her MPH. She completed her dental public health residency at the National Institute of Dental and Craniofacial Research, the National Institute of Health, and is a diplomat of the American Board of Dental Public Health. Currently, she is a dental officer in the Bureau of Primary Health Care at HRSA. Dr. Rebecca Cornille is the graduate of the University of Missouri, Kansas City School of Dentistry. She completed an advanced education and general dentistry residency in Kansas City following dental school. In 2010, she joined Vista Community Clinic with locations in San Diego, Riverside, and Orange County, California, and she serves as their chief dental officer. So with that, I'm going to pass it over to Dr. Hilton to get us started.
Thank you very much, Candace. And sorry, please excuse all the going back and forth on the slides. So welcome to the 2021 HRSA UDS Sealant Measure Annual Update. Candace already went over the objectives, and we're going to review COVID's impact on the measure, review the data elements needed to compute the measure, describe the strategies for improving on the measure, and then learn from Vista Health Center on how they have improved and maintained their UDS measure. So first, we're going to hear from Dr. Adunola with our annual update from HRSA.
Thank you, Dr. Hilton. Hello, everyone. It's a pleasure to join you today to provide this annual update on the UDS Dental Sealant Measure. My name is Lieutenant Commander Shayo Adunola. I'm a dental officer in the Office of Quality Improvement within the Bureau of Primary Health Care at the Health Resources and Services Administration. Next slide, please. HRSA's vision is healthy communities, healthy people. The mission is to improve health outcomes and achieve health equity through access to quality services, a skilled health workforce, and innovative high-value programs. HRSA supports more than 90 programs that provide healthcare to people who are geographically isolated, economically or medically challenged. HRSA awards grants and cooperative agreements. There are currently more than 3,000 awardees. HRSA programs serve tens of millions of people, including people with HIV, pregnant women, mothers and their families, and those otherwise unable to access quality healthcare. Next slide, please. HRSA's health centers are community-based and patient-directed organizations delivering high-quality, comprehensive primary care and enabling services. It is also worth noting that no one is turned away. Services are available to all, with fees adjusted based upon ability to pay. Health centers deliver care to the most vulnerable populations, including those experiencing homelessness, agricultural workers, residents of public housing, and the nation's veterans. Next slide, please. So these are the priorities informing the Bureau of Primary Healthcare's vision and goals. These priorities are to increase access to the health center model of care, ensure that all patients have access to patient-centered services that address barriers to care, deliver high-quality care that advances health equity, and to optimize service delivery. Next slide, please. So again, focusing on the care model of health centers. For millions of Americans, health centers are the essential healthcare home. Health centers provide services that promote health, they diagnose and treat disease and disability, and help Americans cope with environmental changes that put them at risk. Health centers often integrate primary care services, mental health services, oral health, substance use disorder prevention and treatment, vision, and enabling services. In 2020, there were 1,375 health center grantees that served 28.6 million total patients. So at this point, I'll focus on oral health services at the health centers. Next slide, please. So I'll start by briefly discussing BPHC oral health investment since 2015. In 2015, there was the Health Center Expanded Services Supplemental Funding. Applicants proposed to expand medical, oral health, behavioral health, pharmacy, and or vision services with at least 80% of the total expansion service budget. Up to 20% of the budget could have been to expand access to enabling services. Approximately $93.9 million was invested in oral health. In FY 2016, 420 health centers received additional funding to expand oral health services as part of the Oral Health Service Expansion Awards. $156 million was invested. In 2019, the Oral Health Infrastructure Supplemental Funding supported one-time physical and organizational infrastructure investments to provide new or enhance existing high-quality integrated oral health services at health centers. Example of infrastructure investments include minor alterations and renovations, equipment purchases, training and consultation, health information technology, infrastructure investments that improve access, including telehealth and virtual dentistry. About $85 billion was invested to 298 health centers. You can also see on this slide how dental FTEs, clinical visits, and patients served has increased from 2015 through 2019. For dental FTEs, we went from about 14,560 in 2015 to about 16,150 dental FTEs in 2016 and 19,700 dental FTEs in 2019. For clinical visits, we went from approximately 13.2 million clinical visits in 2015 to 14.4 million clinical visits in 2016 to 17.3 million clinical visits in 2019, an additional 5,000 virtual visits in 2019 as well. For patients served, we went from 5.2 million patients in 2015 to 5.7 million patients in 2016 to 6.7 million patients in 2019. So for 2020, we see a decrease in dental FTEs, clinical visits, and patients served compared to 2019. Likely attributable to the COVID-19 pandemic. However, I think it's worth noting that virtual visits went from about 5,000 in 2019 to over 275,000 virtual visits in 2020. Next slide, please. So the National Network for Oral Health Access, NNOHA, is one of HRSA's National Health Center Training and Technical Assistance partners. Since 2015, NOAA has received funds through a cooperative agreement. NOAA provides oral health training and technical assistance for expanding access to oral health and enhancing quality improvement, currently funded at $550,000 for FY21. NOAA also received an additional $137,500 through the America Rescue Plan Act funding. NOAA has received over $3.6 million from HRSA since 2015. So in total, from 2015 through present, BPHC has invested approximately $338.6 million in oral health. BPHC has and continues to support oral health initiatives. Next slide, please. So in 2015, HRSA introduced the first oral health clinical quality measure to the UDS, the dental Sealant Measure, which is the percentage of children 6 to 9 at moderate to high risk for caries who receive a sealant on a first molar. Looking at this slide from 2015 through 2019, HRSA health centers consistently saw an increase in the percentage of children receiving dental sealants each year, outperforming the national average. You see a decrease from 2019 to 2020, which is likely due to the COVID-19 pandemic. And even with the decrease, there was a 6.3 percentage point increase in the dental sealants measure from 2015 to 2020. For 2020, we were at 48.7% for the dental sealants measure. We're still way above the national benchmark of 37% and the Healthy People 2030 goal of 42.5%. Next slide, please. So this map represents the 2020 UDS measure performance by state and the District of Columbia. States shown in the lighter blue have the lowest performance on the UDS measure, and states with the darker blue have the highest performance on the UDS measure. Next slide, please. So again, looking at some of the UDS 2020 data points for Health Center oral health program, I stated earlier, 48.7% of patients with sealants on first molars. For workforce in 2020, about 4,873 dentists compared to 5,324 dentists in 2019. In 2020, 2,486 dental hygienists compared to 2,856 dental hygienists in 2019. And in terms of access, approximately 5.2 million dental patients served in 2020 compared to 6.7 million patients served in 2019. So we noted a decrease in 2020, again, likely attributable to the COVID-19 pandemic. Next slide, please. So this concludes my annual update. Thank you all for this opportunity to share UDS data updates. I hope you find this information interesting and useful. Again, please visit the HRSA BPHC webpage to learn more about our programs. And I have my contact information here on the slide. Feel free to reach out if there are any questions. Thank you again for your time. Over to you, Dr. Hilton.
Thank you, Dr. Adunola, for joining us today. So now let's talk a little bit about the UDS Sealant measure and how to compute it and how to improve our percentages. So this is a review of the measure, and those of you, whether it's your first time joining us or you attended this webinar every year or have been on our conference session, this is something that we hope eventually every health center dentist is able to recite in their sleep. And that is, what is the measure? The measure is a percentage. So every percentage has a numerator and a denominator. And for this measure, the denominator is of all the patients that were seen in the health center in any given year. And in this case, it's 2021 is going to be the year that we're talking about, is how many people in the health center that were seen in the health center were dental patients of record that were aged 6 to 9 during 2021, were at elevated risk for cavities, for caries, and had at least one sealable first molar. So it's 4 criteria that would put an individual that was seen in the health center in 2021 into the denominator of the measure. And the numerator is the number of kids that were in the denominator that actually had at least one sealant placed. I do want to mention right now that if you have any questions at all about how to compute the measure, we have an FAQ, and in the link that Candace gave you to the presentation, the FAQ is listed. It's in our NOAA website. And also, if you have any questions, please chat them in. Every year we have this webinar, we respond to every single question that we get in the chat and email you back with a response individually. So please feel free if you have any questions at the end of the webinar, you still don't understand something, we will put it in the chat and we will respond personally to you. So the measure has been implemented for 6 years. So what we have learned in these 6 years is that health centers, the majority of health centers, have come to 3 main ways, 3 main methods that they use for computing the measure percentage. And the first one is health centers use the EDR vendor solution, what we call push the button. So that means that throughout the year, they're entering data into the EDR, and then on January 2nd, you go to your software, you pull up a screen, you put in like some age or date ranges, then you push the button and your percentage pops up. That's one way. The second way is that for health centers that either don't have an EDR that has a vendor solution, or they're not confident in their vendor solution, you can compute the measure electronically with a workaround. So again, working with your IT staff, you can pull data from your billing records, and you can do this workaround. And again, many health centers do that electronically using Excel, basically. And the last option is to use manual chart audit. So which means to physically open up the EDR or the paper charts and go in and look up the data yourself visually. And if you have the vendor solution, the next couple of slides is going to talk about what's really happening in the elements. This is what's happening in the background if you have the vendor solution. So one little side here is, how do you do a manual chart audit? And every year, HRSA puts out the UDS manual that talks about how to compute all of the quality improvement measures, which is the UDS measure. Sealant Measure is one of the quality measures. And on page 177 of the manual for 2021, it'll give you the sampling methodology on how to do a chart review. It's 70 charts. If you saw more than 7, you had more than 70 kids, 6 to 9, they would like for you to audit 70. And we have some health centers where the denominator is less than 70. So then you have to look at every chart if you're going to use the chart audit method. So what's the goal of all this data collection? All these elements you need to record, need to document throughout the year that will enable you to compute the measure. You can think about data as a giant pie. So you have all the data for all the patients that were seen in your health center across all departments for 2021. That is the pie. It has everybody in it: adult, kids, behavioral health patients, medical patients, dental patients, everybody. And what the data collection, the reason you have to have these data elements is because that's what allows you to take that whole pie and slice it down, reduce it down to just that one slice, which is the patients in the denominator. So again, you're taking it down from your whole health center to just dental patients of record that are 6 to 9 years old at elevated risk for caries that have at least one sealable molar. So to get from here to here, you have to have all these data elements. And that is what the point of the data collection is. So that you will have all the data elements that you need that will allow you to be able to compute your measure, like I said, in January of next year, in a month. So here's the criteria. for the denominator. On this slide, you can see the first 3 criteria to take you from your pie to your slice, your whole pie to your slice. The first is the age. So the denominator is all the kids that are 6 through 9 years old. So for 2021, for this year, that means that your denominator is going to include every child that had a birth date in this age range. Next is that there were dental patients of record, because there was all kinds of kids 6 to 9 that were probably seen in your health center. Not all of them were in dental. So we got to tease out, slice out the ones that were seen in dental. That's what this next criteria is about. And there is a standardized definition of what makes a person a patient of record. And that means that one of these CDT codes must be in the billing, must have been billed at some point in the year. If you look at these codes and you recognize them, what you don't see is D140, which is an emergency visit. So what this does is it eliminates kids that were just seen once for an emergency and not seen again. They want it to be a patient of record that has had an exam or an assessment. So that's why these particular codes are the ones. The next criteria, information that you need to have documented in your data system, is if they're at elevated risk for caries, which again for the measure is defined as having a CDT code. This is the easiest way to identify if they're at high risk. It's CDT code 602 or 603. So again, if you're doing electronic, having this data in the set is what you want, so that again you can pull that data out later. The last element, the fourth element, is the exclusion. So again, to be in the denominator, a child has to have at least one sealable first molar. So that means that kids that don't have any sealable first molars should be excluded from the denominator. So that means, again, all 4 molars are not sealable. Then you would have an exclusion. So here is reasons, these are some common reasons of why all 4, and it has to be all 4, so 3, 14, 19, and 30 molars would be excluded. And that would be, for example, if they're unerupted, if they're extracted, if they're missing, if they have cavities, they have caries, if they are fractured, if they have already had a restoration, so you can't place a sealant, or if it's already got a sealant. So if all 4 molars, first permanent molars, are excluded, the child's gonna be excluded from the denominator. So the exclusion part is the hardest to document, because it's either, well, we'll explain about why, because there's no coding for it. There's no CDT codes for it. So it's not as easy as the patient of record piece or the caries, high risk caries piece or elevated risk. There's basically only 3 ways to address exclusion, the exclusion piece in determining your denominator. One is if you have the vendor solution. So if you have a vendor solution and you've been entering the data correctly for the entire year, then the algorithm of the vendor solution will automatically exclude a child that doesn't have any sealable molars from your denominator. However, you have to realize that the vendor solution, it working correctly, the algorithm working correctly, is dependent on scrupulous, detailed, complete charting of conditions on T3, 14, 19, and 30. So what that means is when you're doing the exam or assessment visit, that if T3, 14, 19, and 30 have any kind of condition that would exclude that tooth from the denominator, that has to be documented. So again, if the tooth has been sealed, that you have to put that down as an existing condition. If it's been extracted, that again, you put that down. If it's unerupted, that is documented as a condition, or if it has a filling or needs a filling. Because if you don't put a condition on each one of these 4 teeth, the algorithm will assume that it's that tooth has a sealable surface and is going to put that child in the denominator. So again, the vendor solution is great, but it's dependent on how scrupulously and completely correctly you charted all of these molars on kids, for the entire year. The other option, another option, is to use an EDR code or a smart code. So for people that are using the workaround method, they usually develop a smart code, a dummy code, two of them. One that is the kid is in the, would be in the denominator, and the other one is that they're included. So it's like a yes, no. Yes, they're in the denominator. No, they're not. And every time they do an exam on the child, 6 to 9, they will enter the smart code. And then at the end of the year, when they're looking at their Excel sheets, that will tell you which kids need to be excluded. The other option is to not deal with the exclusions and not do anything about them and just leave them in your denominator, understanding that if you do that, your denominator is going to be bigger than it should be. So these kids will never make it from your denominator to your numerator because they have no seal molars to seal. So your percentage is going to be lower. So those are the 3 strategies for addressing the exclusion criteria for developing your denominator. We do get questions, and what we've seen in the last couple of years is about excluding, may we exclude uncooperative kids? And the answer is no. We don't like that because, what can you do? Kid is screaming, you can't place sealants on them. But the measure specifications are clear. So, kids being uncooperative, parents refusing sealants, those are not criteria for exclusion from the denominator. The only thing that qualifies for excluding a kid from the denominator is if all 4 permanent first molars are not sealable. And your numerator criteria is pretty easy after all that. So of all the kids that are in your denominator, how many of them actually had a sealant? At least one sealant, just one time during the year was billed the CDT code 1351, which is a sealant code. That's what will move a kid from the denominator to the numerator so you can do your percentage. Whew, okay, so again, if people have questions, whether it's a review or the first time you're hearing this, again, in the FAQ, again, the link that's on our website, we have multi-pages. Again, it explains this in different ways so you can understand everything you need to know about denominator, or again, chat in or in the Q&A, and we will email you some response. Okay, so now we're back to talking about the actual measure. So here is the same information that Dr. Adunola presented earlier about what happened to the measure, because of COVID. Here you can see, and if you go all the way back to 2015, when the first year we did the measure was 42% was the percentage. So what that meant was in 2015, if you were a child 6 to 9 and you wandered into a health center dental clinic during that year and you had a sealable molar, you had a 2 in 5 chance basically that by the end of the year that sealant would actually have been placed. And a lot of work has been done by everyone throughout the whole country, and over the last 5 years between 2015 and 19, everybody had worked so hard, and we had managed to actually pretty much almost flip that to almost 60%, which meant in 2019, if a 6 to 9 year old child walked into a health center and had a sealable molar, there was a 3 in 5 chance that during that year, that tooth was going to get sealed. And you can see from COVID, the impacts of COVID, we dropped back down last year to 48% and basically lost everything we had gained. And, we're pretty much at the same level we were back in 2016. And then let's look at some of this. And again, as was shown earlier, there were less patients seen in dental clinics, in dental programs, in 2020 compared to previous years. And we know all the reasons for that. Clinics were closed in most states for 3 months. A lot of health centers completely shut down, furloughed, laid off all of their dental staff. You can see that by the end of the year, in December 31st, many dental programs had not returned, to their previous levels, and we had lost almost over 1,000 dental assistants, and about 500 dentists, and about 400 hygienists lost from dental programs. And we'll see this year if we have gone back up in terms of levels, but of course that would resulted in less visits. just wanted to briefly go over the workforce ratios. The interesting, and it's kind of interesting because we've been hearing from many health centers, in fact, almost all, that they're having trouble hiring and retaining dental assistants. And this is actually already a trend even pre-COVID. If you look at the ratio of dental assistants to dentists, and this is the last 5 years, you can see that we were at our peak in 2018, probably from all that HRSA investment at 2.35. And it started to go down 2019 and continued in 2020, but it's still actually higher, the ratios, than the levels in 2016, 17, at least based on the UDS data. So there's, again, a little disconnect from what we're hearing on the ground and what the data is showing. Here's the one that we want to spend a little bit of time on. This is the actual measure numbers from the UDS numerator and denominator measure. So the denominators, the big numbers, is in the gold, and the numerator is in the orange. So what you can see is here you can see between the 250,000 and 167,000 is the drop in kids in the denominator. And this is because less kids were seen, less dental patients, less dentists, less assistants, closed clinics, less patients in all dental programs. So again, of course, there's going to be less kids in the denominator. But as far as the UDS measure, which you've got to remember, is it's a percentage. So even if the denominator went down, the percentage of the numerator could still have been higher. So what we're trying to say is, what this data shows us, what these last two bars shows us, is that a bunch of kids came in 2020 and had sealable molars. They had exams and they had sealable molars, but they never came back. They never got the sealants done. That's why the percentage dropped, right? Because it's a ratio. So and there are many reasons, why this happened. Maybe there was a lot of kids. There were some kids, that came in and had an exam done in January, February, and March before everything shut down, and they were identified as having sealable molars. Maybe the clinic never reopened. Maybe the clinic stopped doing sealants because it's an aerosol generating procedure. Maybe we didn't do such a good job, with so many competing needs. We didn't do good jobs of bringing kids back that, again, had sealable molars so they could get them done. There's a lot of reasons, again, why the actual percentage, the ratio went down. And so part of what we're hoping to do with we're hoping that in 2021, the percentages started to go back up. And certainly we're hoping that for 2022, we can refocus everybody on getting back to placing sealants and making up the lost ground and getting back to where we were before, as far as, almost having 3 out of 5 kids actually get sealants in a year. And so here are the top 6 things that we, after again working with multiple hundreds of health centers on helping them improve their measures, that we have found that health centers have developed to increase their UDS sealant measure percentages. The first thing is to treatment plan more sealants. Just think any child that walks in 6 to 9, actually 6 through 14, first and second molars, that has sealable molars should get them sealed, irrelevant of the caries risk, low, moderate, high. That's actually the latest ADA guidelines from 2016 recommends sealants, again, for all children, regardless of caries risk. And again, it's even more important because we understand now, again, aerosol generating procedures, there's less aerosols generated in sealant placement than there can be less aerosol generated than if you're doing a restoration on that same molar. So again, sealants prevent cavities, and that's less aerosol generating procedures. Equipment. So changes in equipment, modifying your equipment, looking at your equipment can help you raise your UDS measure rates by doing more sealants. More efficiently doing sealants. The first thing you want to look at is curing light. If you get a curing light, if you're currently in the curing light that's 20 to 30 seconds versus the newer ones that do 5 to 10 seconds, over a whole day, you can actually save enough time to add another patient to a sealant column by using a faster light. Using one of the moisture isolation devices like ISO Dry, ISO Shield, Dry Angle, Dry Sheet, so many now, but they all, again, work, make it easier to do sealants, just one person without support staff. And also, again, a lot of them include suction so that you're able to, again, minimize aerosol generation. And then materials, again, resin, glass ionomer. We know we had a webinar last year, glass ionomer, again, minimizes the amount of aerosol generation in sealant placement. So again, if that's a concern, if you're able to, and I know this can vary by state because in some states and Medicaid may not, or a school-based program, it may not allow you to use glass ionomer, but if you can use glass ionomer, we urge you to go back and look at our sealant webinar, the webinar we did on placing glass ionomer sealants last year. And this is a brief slide of the technique. Again, using cotton rolls and wet cotton rolls to clean the teeth and wipe off the conditioner. No need to use an air water syringe because again, it's hydrophilic, water loving material. And then using the thumb, squish thumb technique. We'll hear more about that later. We wanted to we're curious to do a poll right now of everybody that's on about what sealant materials you are currently using to see if there's been any change in the materials that people use because of COVID. So how many of you right now are using resin only versus are any health centers that are using glass ionomer only, or how many of you are using both, depending on the clinical indication? If you could just do one of these, check one of these, and we'll see where everybody's at right now. Okay, so the majority of you, this actually is a change from previous polls. We'll just say pre-COVID, we were still in the majority of people were doing resin only. So the fact that the majority of people are using both, depending on the situation, is a change, like I said. So it's really interesting to see that. Thank you. So again, another strategy for placing more sealants is to make sure that you're using your support staff and other dental team members at the top of their scope of practice. This is the dental hygiene wheel, and the orange circle are the states where hygienists can place sealants without a dentist seeing the patient first. So for health centers that have school-based programs, if you're in one of these states, that is the great way to get more sealants placed on more kids, again, by sending, having your hygienist run your school-based program and having them go out and screen kids and place sealants. If you're in the clinic, in the dental clinic, and you're in a state where registered dental assistants can place sealants, then again, that's a good use at the top of the scale that can work in synergy with a dentist, again, maximize the number of sealants that are placed. Other strategies for placing more sealants is to develop, standard workflow and standard policies. For example, something like if a child comes in for an exam and they don't have any cavities, that the sealants, will be placed on the same day so that they don't have to return. Again, as we've seen from COVID, the maximizing what's done in a visit, minimizing the, time that patients have to go on buses and public transportation. We really understand that more than ever. So again, maximizing what happens in a visit, and that even if a child has cavities, again, making sure that sealant and treatment planning sealant is part of the comprehensive treatment plan, and prioritizing, this goes to the next slide, prioritizing sealant placement over routine restorative. This is a big paradigm change for many dentists, especially if you have been out of school more than 15 years. This is not how we were taught to treatment plan sequence. You know, the sealants usually were at the very end after we had done all the restorative, or you were doing it in quadrants. So sometimes, you know, again, if you have 2-3 months between appointments at a health center, that meant that a first molar might not get sealed for a year, right? For 6 months to a year. And if you compare these two treatment planning sequence, we have the traditional one here, where again, you do the exam, x-rays, propylene fluoride, then you address, you know, the abscess and the caries, and then finally at the end, and then again, like I said, we have wait time between appointments, you do another recall, and by the time you get around to these molars that at this point, you know, have nothing on them, but are perfect grounds for strep mutans, cavity causing bacteria to, you know, invade, they will have cavities. So now the new paradigm, again, the change in paradigm is the patient comes in, you know, they may, if they don't have symptomatic, you know, again, you're doing the exam, it's sealed. There's really nothing we can do to prevent cavities in these 4 teeth, but we can prevent cavities in these 2 teeth. So again, prioritizing sealants over routine restorative. But even if it's an emergency, maybe you're extracting this tooth while patient is getting numb, sealants could be placed on these 2 teeth and then go into the restorative. So again, a paradigm change that puts the patient and what's best for the patient, which is preventing more cavities as well as treating, you know, urgent needs first. And the number one strategy, again, that we've seen health centers develop, you know, organically within themselves to place more sealants is same-day sealants. And in the work we've done with health centers, we have seen so many promising practices and ideas on how to place more sealants, like using, you know, during your huddle or using your EDR alerts to identify kids 6 to 9, having trays ready in every room, every exam room, so that you can, if you need to do sealants, everything is already there. Again, using your team members to come in as opposed to moving the patient, bringing the team members to the child. Again, working on same-day sealants. And for health centers where you have hygienists embedded in the medical clinic, this is a great use for the utilization if they see kids 6 through 14 in primary care, to be able to place sealants on the same day. These are, again, just some strategies for placing same-day sealants. Again, here are the resources that we mentioned, the FAQ and the Sealant Glass Ionomer webinar. Now I'm going to turn it over to Dr. Cornille from Vista, who will talk about what they have done to increase their UDS measure throughout the last couple of years.
All right, good morning, everybody, or good afternoon, depending on where you are. I'm Rebecca Cornille. I'm the Chief Dental Officer from Vista Community Clinic. And I'm going to share with you today kind of our improvement efforts. So most of the time at the end of these presentations, we present the success or the expert, and I'm by no means the expert, nor have I achieved success yet. I'm kind of in the midst of putting all the pieces together. So hopefully you can glean a little bit of information from what I've struggled through to make improvement at your health center. Next slide, please. So as I mentioned, I'm in California. We're in San Diego, Orange, and Riverside counties. These are our clinics listed here. Those with the little star next to them are co-located clinics. So we have medical and dental there. The others are solo. We down towards the bottom, you can see our mobile units. We have a mobile medical unit, a mobile dental unit that's fully equipped with 2 operatories. Another mobile unit that does our A+ program, which is a robust sealant program. We do pop-up vaccine events for COVID. And then in the center at the top is our mission location in Oceanside, which is our only lone standing dental clinic that we actually opened in July of 2020 in the midst of pandemic. And it's a pediatric focused clinic. Next slide, please. We offer a myriad of services, as you can see listed here. We do formal, collaborative, or integrative work with several departments departments, including family medicine, pediatrics, our women's health and prenatal programs. We have just started working on an optometry integration this last year. That's been pretty exciting to focus our diabetic patients on optometry and dental care. And our electronic dental record is next gen QSI. Next slide, please. So based on 2019 UDS information, we had 7 primary care sites and served almost 60,000 patients. Currently, we're up to 9 sites, so we've grown some in the last couple of years. In 2019, we had 4 dental sites serving almost 19,000 patients. Now we're up to 7 dental sites, currently 5 are brick and mortar sites and 2 mobile units. Next slide, please. So for our VCC UDS sealant data, in 2019, we were at 44%, and in 2020, we were at 46%. So in the center there, you'll see there was a call for applications for the Sealant Learning Collaborative, and we jumped on this because we want to do better. So that started at the beginning of this year in January to May. We participated in the Sealant Collaborative, which I highly recommend. It was super helpful. And we set a lofty goal of 53% for 2021. Next slide, please. So basically, I have learned that through the collaborative and through this process that there's 4 key areas that I really needed to focus on. One was process change, one was clinical change, education, which I can't enforce enough, and then workflow change. So for our process change, one of the things that we learned through the collaborative was process mapping and really how to implement change, identify opportunities, work through them, revamp our plans if they don't work out quite right, and just constantly looking towards improvement in efficiency. Another big thing for us was accurate data collection. So over the course of my tenure with the clinic, we've kind of jumped all over the place with our sealant scores, and we were trying to figure out what the difference was. And some of it was data collection. We have struggled with no vendor solutions, so we've had to implement smart codes or dummy codes, however you want to name them. And then also making sure that we have quality folks working with us that fully understand this dental measure. Since they're very focused on medical, there's a learning curve there. So we modified smart codes within our EDR, and that little snippet at the bottom is an example. So I was emailing Dr. Hilton, I think we're missing something here, and we made some adjustments to our inclusion and exclusion codes to make sure that we were capturing the patients that we needed to and getting our data correct. Right there, perfect. And then clinical change. So we moved to glass ionomer sealant placement during COVID because we were trying to minimize our aerosol generation. And on the bottom left there, you see a photo from a video that we actually put together as a training model for all of our clinicians. So we did experience furloughs. We had folks out for periods of time during COVID, and basically, when they came back, I told them, you're coming back to a whole new job, new levels of PPE, new equipment, and new ways of doing things. So we needed to train people on how to place glass ionomer sealants if they didn't have experience with it. And we also acquired isolation systems. So we actually got IsoLite and IsoDry. And so part of that video is also instructing on how to use it so we could train our assistants and our hygienists and dentists. Next slide, please. The education was a big part. So I think a lot of us in leadership attend these webinars and we learn about these things and we go back into clinic and we do them. But when you have a really large team and you're leading a really large team, it's disseminating that information to everyone within your clinic. I have over 25 dentists and I want to make sure that we're all on the same page, which is challenging. So it's making sure that we're updating our practices and sharing that clinical background and that data-driven information to make sure that we're practicing accordingly. We have a broad range of dentists with different years of graduation and training, and so trying to get everybody on the same page, it continues to actually be a little bit of a struggle, making sure everybody's informed. And then there's those workflow changes. So trying to get the buy-in from everybody to try those same-day sealants. Yes, you know, COVID's been challenging, that things are taking a little bit longer, staffing issues come up, but can we reach those patients while they're in the clinic versus sending them away? And another idea we've been working with is what we've called the Sealant Express, which we're in process of. We're kind of in this finish line crunch for this year and really targeting those patients. And we've created a schedule to get those patients in as quickly as possible. And next slide, please. So improvement strategies that we implemented, as I mentioned, the glass ionomer sealants, the isolation systems. We also have done a lot of targeted reporting and appointments through that Sealant Express, and also just through our general, the patients that we focus on when we do have open appointments are these patients. We modified our quality incentive for our team in July. So we have a pretty robust quality incentive program. One of it includes, one of the measures is sealant placement, and we've adjusted that to incentivize dentists and hygienists for placing those, and then the assistants are thereby incentivized if their teams meet certain goals, and that's been helpful, although we've only had that in place for half this year. And then sending out these emails. So at the bottom, I have a wonderful dental manager who is the right side of my brain, essentially. And on a monthly basis all year, he sends out a report on how we're doing on dental sealants and a specified patient list to target those patients. And then in this last quarter, the interval has decreased to every 2 weeks to make sure we're continuing to focus on those patients. And then a consistent quality team is really important. So as I mentioned earlier, we were kind of all over the place, and I think a lot of it was data capture. And now we've had a consistent quality team for some time who fully understands the measure. And it's been a lot easier to work through it in the last couple of years. Next slide, please. Some challenges during COVID. So as we've already mentioned, for a period of time, nothing was happening. So there was a lot of catching up to do. Personally, I've experienced a lot of hesitancy of parents bringing children in because of fears. You know, everywhere you go, you wear a mask, and then we ask you to come in, take your mask off, and leave your mouth open. And it's scary. It's scary for parents. It's scary for patients. We had to make sure our procedures matched our COVID protocols. So that was moving towards the glass ionomer sealants and trying to minimize our aerosol generation. And then there was a lot of virtual learning in California. So our school-based programs really suffered. Kids weren't at school. And we tried to find ways to reach them, but that was challenging. And we've had a partial relaunch this fall with schools back in session, and the schools being willing to prioritize us coming in to help out when they have a lot of competing interests right now. Next slide, please. So we limited aerosol generating procedures, as I mentioned. We did some integration efforts in our pediatric department in women's centers. So when those kiddos and pregnant women were in for visits, we were doing a lot of warm handoffs or same-day visits with dental to try to make sure we minimize the number of visits they needed to make to the clinic. We implemented those isolation systems, and then we also worked with our outreach team during virtual learning. So when we couldn't reach children in school, we tried other ways. We have a very large food distribution program, as well as a diaper distribution program. So we sent our mobile team to those same events to try to capture some of those patients while they were receiving those other services from the clinic, and completing dental assessments. So on children, on adults, whoever needed our help, we tried to be there to support our community. Next slide, please. And just a little bit more about the isolation system. So we got the Isolite system to minimize aerosols. It's worked really well. Our clinicians have adapted to it very well. They love the illumination and they love the suction feature. Makes things a lot easier. It frees up your assistant a little bit. In times of short staffing, which a lot of us are experiencing, it just gives you a little more latitude to work. Challenges, some patients do not tolerate it well. Those with strong gag reflexes, the size, jaw soreness, things like that. So it's not a one size fits all, but it works for most. We created a training video, as I mentioned, and there's additional equipment costs, obviously, for the initial investment, and then the reoccurring mouthpiece costs for the insert into the actual unit. It's helped increase sealant rates because we've been able to schedule a little bit more with more flexibility, less staff, better isolation. So hopefully longer, higher long-term success. Next slide, please. And then glass ionomer sealants for sealant placement. So we decided to do this because of the aerosols. It's working well because it's fast, easy to use, less sensitivity to moisture. We've needed to provide more instruction for use and help facilitate that material mind shift. A lot of the dentists weren't feeling quite as confident with them. So that has been a steep learning curve there. And then also because of that quality incentive program that we have, there was a little bit of fear over moving to something new, because one of the things we look at is how often things need to be redone. And if they didn't feel confident in the placement of the sealants, they didn't want to be penalized for having a failure. So we've had to work through education and practice and really training for everybody. And as I mentioned, it's faster, easier to use, easy to provide in more mobile and portable settings based on the material. And the fluoride release, there's just so many great features of glass ionomer sealants. Next slide, please. So here's our 2021 data I humbly present. So again, like I mentioned, I am not an expert. We are very much in the process of improvement. So we finished our collaborative in May or June. And we got really excited when we saw a big jump from May to June in our completion rate. And then all of a sudden we plateaued. So in the summer, we see a lot of kiddos and a lot of kiddos prepping to go back to school. So our denominator really increased during those summer months, which is great. We love seeing kids, but we're like, oh no, this is not so good for our sealant completion here. So we're in our final push for the year. Currently, we're at 46%. So we're tied with last year, but we have a lot of big plans in place for this final month. And we're hoping that that'll bump us up a lot. And really our focus next year is going to be to bring all these tools together, all these things that we've learned, and make a year-long concentrated effort on improvement. This year has very much been a year of transition for us and a challenging year with COVID. But I really feel hopeful for next year in terms of being able to make some good progress here and better successes. And next slide. And that is it.
Thank you so much, Dr. Cornille. So if anybody has any questions, and actually there is a bunch of questions for you, Rebecca, about your incentive system. So I'll let Candace take those. So I see everything. I did respond to one question in the Q&A. So Jessica St. Clair, if you can go to the Q&A, I answered your question, hopefully. Every other question that's in the Q&A, we will respond, like I said, to your emails. How much time because we only have 2 minutes, but actually, since there's a bunch, Candace, the questions about the incentives. Oh, you're muted.
Sorry about that. Yep. Yeah, so the question is, what are the incentives, Rebecca, for your providers in placing sealants? Are they monetary? Are you doing additional things?
Yeah, so a really short version of what we do is basically a combined program of access goals, so a productivity goal, since that is how we were paid, combined with quality metrics. And I believe NNOHA has a pretty robust system on their website to set something like that up, but one of them includes sealant completion. It is a monetary system, so it's goal setting for sealant completion rate. We do it on a quarterly level, and and it's tiered. So if you hit a certain percentage, you might qualify for what we call the minimum performance level, and then there's a high performance level. And our minimum performance level is based on averages, whereas our high performance level is based on improvement. So it's a complex system, works very well. I'm happy to share more at another time because it's not a 2-minute conversation.
Great, thank you. And I want to just address 2 anonymous questions. I won't be able to contact you, so I just want to ask them now while we're on the call, whoever asked them. The first one is probably for Shayo. Are there other UDS dental metrics on the horizon, or any that are not required but recommended?
I had to make sure I was off of mute. We're having internal discussions, so more to come on that, but that's something that we are looking at.
Okay, great. And then the last anonymous question, can non-PCAs obtain state level aggregate data for indicators that are not provided on the HRSA website?
I can ask you, anybody can request data, UDS data, public data through the HRSA website. Then they will decide whether or not they can give you the data, depending on who you are and why you want it. So, and depending on what data you want, because there's some data that's public and then there's other data that's not. So I'm also going to say, if you're looking for other quality measures, we do have a dashboard on the NNOHA website, a quality improvement dashboard that has a set of 15 measures, both clinical and operational, that you can think about implementing if you want to do a quality program. And I know Dr. Adunola cannot say this, but I can say it, that a couple of years ago, HRSA did actually put out public comments about a fluoride varnish measure. Hint, hint. So that was not adopted. The sealant measure continued, but I'm just saying, if you're thinking about what might happen based on what has been done in the past, that may be a possibility.
Well, thank you so much to our speakers for this really informative presentation. If we weren't able to get to your question, I know there are many that we were unable to get to. We will email you with a direct response, so stay tuned for that in the next week or so. You can also email any additional questions you have to info@noah.org. And I've also put into the chat box the slides for today's presentation, as well as a recording link to a webinar that we had on class Ionomer sealants. Attendees will receive a copy of the presentation slides and a link to the survey shortly. It'll also pop up on your screen, and the slides and recording will be on our website next week. If you are requesting CEs, please complete the survey no later than Tuesday, December 7th. And now this concludes today's webinar. Thank you so much for joining us, and enjoy the rest of your day.